Two, one. Good afternoon. This is Dr. John Bennett, broadcasting from Miami, Florida. We have another in a series of weekly Larkin Hospital TV Hangouts in the Neurosurgery channel. Once again, we have Richard Mendel MD, a spinal neurosurgeon from Tampa, in St. Petersburg now, actually. He is a dedicated medical neurosurgical educator, and we really are thankful for him for doing these. We're going to introduce first the panel before we turn it over to Richard. So why don't we start with you, Lisa? Unmute yourself and introduce yourself.
Hi, everyone. I'm Lisa Cornforth, and I live in Northwest Arkansas. I'm a second-year medical student at Oceana University.
Welcome, Lisa. Muhammad?
I'm Mohammed Aburawi, a medical graduate from Libya, currently a research fellow at Mass General Hospital.
Well, welcome, Mohammed, and I hope you become part of these Hangouts. And Sajish?
Hi, I'm Sajish Kriakos. I'm a head and neck surgeon. I'm living in Miami, and I joined these Hangout meetings with John and the whole crew, and it's been a great experience. And looking forward to your talk, Richard. And nice to see you on board now. Welcome again.
Yeah, Sajish was nice enough to take me to his class, and I talked a little bit about what Hangouts are. And he'll also be starting a head and neck surgery channel. And Simon, welcome.
Hello, everyone. My name is Simon Downs. I'm in Tokyo, Japan. I'm a developmental psychologist and a second-year medical student and a FDA correspondent for a bone-conducted hearing aid. I'm looking forward to this presentation. Thank you.
Very good. Welcome, Simon. Ben?
Yes. Hi, everyone. My name is Van Mulpuri. I'm an internal medicine physician. I'm from Michigan. I'm glad to be here.
Welcome, Ben. Okay, Richard, it's all yours.
Okay. Hi, everybody. I thought we would talk today about spinal balance and the importance of sagittal alignment and sagittal balance. This is a subject that the pediatric scoliosis surgeons have looked at it for years, and they've really pioneered the field. Now, in terms of getting the attention of adult spine surgeons, guys that were doing pediatric scoliosis as well as in a university setting as an academic doing adult deformity as well, started to recognize the importance of sagittal balance in the management of patients with spinal disease. Sorry. And there started to be a movement, really about 2005 or 2006, where a lot of people recommended measuring the pelvic angles and establishing preoperatively what type of realignment needed to be performed to get a satisfactory outcome. So, just doing a neural compression, correcting a neural compression and impingement or instability without addressing the sagittal and coronal balance is not going to result in a very good outcome in most patients. When you're treating a 1 or 2 level disease, it doesn't become as critical. But when you start when you start seeing patients with bad balance and loss of lumbar lordosis or loss of their cervical lordosis, people that have flat back syndromes, you really have to, realign the entire spine and make adjustments according to that. And so I'm going to show you some of the measurements and some of the techniques that started to be done a while ago, and a lot of this talk derives from the Johns Hopkins Spine Workshop that is every August in Baltimore. So this slide, the global alignment slide from Dr. Dubasset, demonstrates what's called the Conus of Economy. And as you age, this conus gets narrower and narrower. It's the amount of resistance to imbalance that you have as you're going through life. And what happens is that you're really able to compensate for smaller and smaller imbalances as you get older. And Dave Polly from the University of Minnesota, one of his favorite things at the beginning of the Bethesda dissection courses, which were in the 90s, he used to say that, you know, life is a kyphosing process. And what he would show is, like, you know, an embryo in a fetal position, then you grow up through infancy, childhood, teenage years, get to middle age, and you're standing very straight and erect with good posture. And then it shows you gradually kyphosing forward till you pretty much have fallen into your own grave. And that's what he used to say, is life is a kyphosing process. So this is an idea about the sagittal balance. This is the spine in the sagittal position, and this is the plumb line that gets drawn from the bottom of C7, the mid-body of C7, down to intersect at the rim of the pelvis, at really the tip of the sacrum. And this shows how when you start to kyphose forward, your alignment and balance really gets quite distorted, and you require more and more energy just to resist gravity, just standing. So while you're young with good posture, you're very efficient in terms of utilizing energy to stand. But as you get older and your plumb line shifts in an anterior position with respect to your own pelvis, it takes more and more energy just for you to stand and resist gravity. And you'll notice that people will tend to flex at the knees, and they burn out their quadriceps muscles with a continuous effort to have erect posture. Now, this is a really visual talk, so, you know, I don't want to throw a bunch of terms at you. You're going to have to kind of think about the spine in 3 dimensions now. Here's somebody that has a curve, a major and minor curve. And, you know, this minor curve is developmental to adapt for this upper scoliosis, so that the patient is actually balanced with the face and head right over the pelvis, at least in a coronal plane. And now you're looking at, and this is, of course, the sagittal plane, but, you know, this is something that, you know, the patient's going to be usually well compensated if their balance is in line, and in this patient happens to be. Now here you see the diagram where you're shifting forward. This diagram here gives you an idea of the sacral slope. Your sacral slope is fixed. That's not a measure that changes once you're mature. Here is a demonstration of somebody who's been corrected. Now, this patient is actually, I'm sorry, I don't have, the pre-op patient had been instrumented, but the coronal and sagittal curves were way off. So the patient really didn't get much improvement in terms of their gait and stability because they weren't corrected in the sagittal plane. Here you could kind of imagine where the head is right over the pelvis, which is excellent. Okay, so again, here is the here's the pelvic incidence where you're measuring the PI and the pelvic lordosis. So if you have a large pelvic incidence, you're going to have a kind of horizontal sacrum. You notice this sacrum is pretty much horizontal. Okay. Now this is a what we call a I'm sorry, this is the horizontal one, but this is the vertical sacrum. Now, try to think of, if you were going to do surgery on the patient's L5-S1 disc, you would have to get a really low angle coming in over the pubic bone to even get into there. And this would be a tremendously difficult case because the L5-S1 disc is almost vertical, and you would have to slide a graft in there at an extremely steep angle where you would have a spreader going into this. It's going to have to be a long instrument. Here you could see that doing an anterior lumbar inner body fusion through the belly, you can get a graft in there very nicely. It's very even. The instrument's just going to be angled like this. But here, the instrument's angled down, you know, over the genital area just to get into that space. So that's the example of the small pelvic incidence versus the large pelvic incidence. So this is your estimate. This is your lumbar lordosis equals your pelvic incidence plus or minus 10 degrees. So you're always going to have a plus or minus about 9 or 10 degrees. And that'll estimate you and get you into the proper ballpark. Now remember, if you're doing an L5-S1 disc or a microdiscectomy or cervical discectomy and you're affecting one level, you're not going to change the patient's overall balance very much at all. But when you're trying to correct a flattened curve, you've got to do it over many levels. So it becomes more important when you see a person who over the years has had many operations, L4-5 may be fused, 5-1's fused, all of a sudden their lumbar lordosis is gone now, they've got a flat back syndrome, and they're walking in a really slouched over fashion. And another thing Dave Polly used to say is that the purpose of the spine is to be a like rigid mobilization for the extremities and to allow the head to be in such a position that the eyes look out at the horizon. If you're not able to look out at the horizon, if you're always looking down, it's really a disabling type of posture. So here again are your measurements. Here's the pelvic incidence. Okay. Now you take the lumbar lordosis, which is here. Okay, measured from the top of L1 to the bottom of L5 or the top of the sacral slope, and you get a number. Then you take your pelvic incidence here from the head measured from the center of the acetabulum, and that's your pelvic incidence. This is the most important parameter when you're doing these measurements. Now, don't worry about all these measurements because I'm going to give you a program, an app you can go to, which is free, and you could play with all these measurements yourself and kind of learn what I'm talking about. It takes several runs through this to get it really cemented in your head. This parameter is the one that correlates most with your outcome scores, and here's the second measurement now. The SVA and the incidence of T1, where you're looking for the amount of curvature through the thoracic spine and its balance over the pelvis. Okay, so again, this has positive correlation with your outcome scores and your pain scores. Okay, now this parameter is how much retroversion you have. And this is from Dr. Steve Glassman, a professor at the University of Louisville orthopedic department. He, John Johnson, and Dr. Dymar, especially Dr. Dymar, is like one of the brightest people in spine. Dr. Dymar knows everything in spine. His lecture about these measurements is one of the best I've ever heard, but he talks about retroversion and how you swing your pelvis to adjust for any imbalances that you have. And there becomes, as you get older, there's just a worsening of your ability to compensate. Now, it's called the plumb line anatomy, the plumb line shift. And what happens is, as you age and you kyphose forward, you see that your cervical lordosis is starting to come significantly forward. And so your lumbar spine compensates for the thoracic lordosis, and you fall into what a positive sagittal balance. A negative sagittal balance runs backward because the plumb line is opposite, and this has significant effects on the kyphosis and increasing disability. Now, here, this is an example of your curvature measurements, your pelvic tilt, and the thoracic kyphosis, and the lumbar lordosis. And like I said, you have an estimate where your lumbar lordosis, if it's within the pelvic incidence in plus or minus 9 or 10 degrees, you're probably in pretty good shape. But once you get a person who's older and unable to compensate and they're really off balance, that cone of economy becomes very small. Instead of being a wide thing like a tilt-a-whirl when you're a kid in an amusement park, you become more like a person standing in a phone booth. If that cone of economy is that small, you're at high risk for falls, pain, and a lot of disability. Now, I can go through this with you and go through all these measurements, but I don't think this is going to help you as much as if you go to an app that's called Surgimap, and a bunch of corporate sponsors donated to this. Many corporate sponsors. Like, I don't want to leave anybody out, but I mean, it included everybody from DePuy, Medtronic, I think Nuvasive, Synthes. A lot of companies contributed to this, and it's a very good app for not only a spine surgeon, but really any surgeon or physician interested in posture and spinal biomechanics, because calculating all these transformations is really, it really requires like a three-dimensional view on things, and it's really the purview of like matrix algebra to see, where something goes in 3D when you're measuring in a 2D plane, like coronal versus sagittal, and how you put those numbers together. But if you go to Surgimap, I think you could find surgimap.com. I think you could find a very good tool that you could play around with and get a better understanding of the posture and the elements that go into the posture of the spine. Now, another free resource that would be good for you is to go to the Scoliosis Research Society website, which is srs.org, I think, and look at their textbook called the e-text, and it's free. The e-text is free. You can download it. And the SRS, the Spinal Research Society, Scoliosis Research Society, is a very, very academic group of very bright guys that really pioneered scoliosis surgery. And so they've gone through and created a textbook called the e-textbook. And you can look at that and answer a lot of the questions that you have by looking through that. But I would really encourage you to play with the surgeon map and see the kind of things you have to take into consideration when you're doing a case that's more than 1 or 2 levels, where you're going to really want to give consideration, especially if it's a patient that's status post a several level fusion who already has impaired biomechanics. You don't want to fix them in a way that doesn't take the coronal and sagittal balance into account. Or you may find, even though the deformity looks better and it looks more stable, you haven't improved them at all because the energy they have to expend just to stand is difficult. So I think that's a pretty good little introduction to sagittal balance and spinal balance. Remember that Conus of Economy and how it gets smaller. It starts as a really wide cylinder and it ends up like a telephone booth when you're old. Okay, I think that would be, really that would be about it in terms of the slides.
Okay. Okay, Richard.
This is really a good topic for people that are interested in mechanics and physics and balance and all that. But a lot of people do get interested in this. A lot of pediatricians got interested in gait disorders of children, and we learned a lot from that too. So.
Very good, Richard. To get off the screen share, just click on the green arrow so we can see you. Once again, thank you, Richard, for a very clear presentation. I'll start things off. One of the longest operations I ever scrubbed on was the Harrington Rod, which I think you had a slide of Harrington Rod. Were those Harrington Rods that we saw?
Well, actually, those weren't. But okay. Dr. Harrington was the pioneer of pedicle screw instrumentation here. I think he was in Minnesota. But the Harrington rods actually had the one disadvantage of fusing people in distraction. And okay. We found out over the years that you really don't want to fuse somebody with a distractive force. You'd rather fuse with a compressive force.
Okay.
So most of the most of the rod systems today use a pedicle screw attached to a rod, and the rod is placed into compression. The ability to place the spine in compression is much more biomechanically advantageous than doing it in distraction.
Oh,
and so with Harrington, they used to have hooks, and so the hooks would be splayed apart. But that was a great advancement. But now that we do everything in distraction, we use systems that are different.
Yeah, that was 30 years ago. Another quick question, Richard. Do you do your own measurements? You use X-rays, right, to do the measurements?
Oh, yeah.
Do you yourself do the measurements?
Well, you guys could do it too. When you get this surgeon map thing, you'll see. You'll be able to do it.
Oh, okay.
And remember that you know, we're in a period, at least in this country, where we've gotten so far away from X-rays. I think it's terrible. I mean, I know X-rays are a source of radiation, but you know, you can't make spinal measurements on MRI. You need X-ray or CT scans to make the correct calculations for correction of bone issues. You can't. I don't think you can do it very well off of an MRI.
Okay. Okay, Simon, Sajish, Mohammed, any questions? Ben, go ahead, Ben.
Yeah, I've got a lot of questions.
Okay.
A lot of questions. I don't think the time would be enough today.
Okay, whoever.
Because this spine creates a lot of problems, like, you know, starting from back pain to disc prolapse to, you know, all these imbalance to all these problems. So I'm just wondering, so when you say sagittal alignment, is it from back to front alignment you're talking about?
Yeah, let's think about it.
Anterior, posterior?
Yeah, sagittal is going to be a cut. All right. If somebody's standing erect with the nose facing the right side of the screen, that image, that's a sagittal cut.
Yeah, I do understand. It's like splitting the brain into two halves. That's the sagittal.
And yeah, but a coronal cut is like looking into the face and splitting in that plane, like an AP plane.
The shoulder spleen. Yes, I mean the plane.
Yeah, so you have your coronal, your sagittal, and the transverse planes. You know, your transverse planes are like slicing a person like bologna, okay? From top to bottom. A sagittal is slicing from anterior to posterior with them standing at an angle from the side.
Right.
And a coronal is a facial view and going from front of the head to back of the head.
Right.
So, you know,
yeah, I do understand what is sagittal, but I'm wondering is, you know, what is the problem with positive scoliosis? I mean, positive sagittal balance versus negative sagittal balance. How does it affect the?
Well, what happens is when you're a young person and you have a cone of economy that's very wide. So at your shoulder level, your cone of economy may be a yard, whereas at your feet it may be 12 inches. And so you can maintain your balance very well when you have a efficient cone of economy. But as that cone folds up as you age like this, it becomes a phone booth where you really can't adjust well for deformations in your posture or balance. And so you, as you resist gravity when you're young, it's easy. You don't even think about it. You're very able to resist gravity. But as you get older, it's tough to resist gravity. You have to expend more and more energy just to maintain an upright posture. And that's why when you watch somebody that has a flat back syndrome, when they come into your clinic and they've been fused by somebody and their back doesn't have a nice curve, lumbar curve in it, when that back is flat, you'll see their shoulders and are stooped over their waist to an extent, and their posture is awful. And they've got and what that person has to do to look at you, because he's looking down at the ground, to look at you, he can't really move his spine. So what does he do? He tilts his hips forward and he bends his knees. And he uses his quadriceps, he uses extensor muscles all the time. And it's so, like, even though he's walking on flat ground, because he's throwing his whole body backwards to compensate, it's like he's going on a continual staircase all the time, even when he's walking flat. And you know, that's just a lot of energy to expend
It's true.
for not much. So you know, this is the kind of thing, I never learned this as a medical student or even as a neurosurgery resident. This was really the purview of really smart guys in the Scoliosis Research Society. I like to go to it. I'm not even a member, but I just go to hear them talk about it. That's all.
So this problem involves, you know, from top to bottom, then, you know, from joints to muscles.
The whole body.
Yeah,
Okay.
right.
It's like Dave Polly used to say. He used to say this. There's several purposes of the spine, and one is to provide the most biomechanically effective anchor for your extremities. The other is to efficiently carry your head in a fashion that your eyes look out at the horizon, and you know, it's very practical. That's exactly, you know, what it really does.
Okay, very good. Mohammed, you have a question?
Well, actually, I'm quite distant from the field, but I'm quite enjoying the new perspective about spinal surgery. There's definitely a lot going on in the field. Just I would like to ask a question is, how much can you tolerate when you're doing corrections? What is really correctable in terms of a deformity or misalignment?
Yeah, that's a great question. You know, with children, and I am not a deformity surgeon at all. I'm a neurosurgeon who just learned a lot from good scoliosis surgeons. I don't do pediatric scoliosis, but what they do, it's almost like watching magic. A guy like Peter Newton, and he used to do these endoscopic procedures, and it was like watching a magic show. But yeah, you know, the pediatric spine is incredibly flexible, and tremendous type of curves can be corrected. I think when you see adult spinal deformity, I mean, those could be big, long operations without a lot of significant correction. But you know, it's kind of a long run for a short slide. So I'll be the expert on that. When you see some of the things that like go on at the Shriners Hospital, where you have good pediatric scoliosis guys, it's really amazing what they can correct. And you know, it also, I think it's like somebody like Rick Sasso, who's done so much in the way of research in spine. And he's done fellowships in oncology, scoliosis, everything. And you know, I think it helps him a lot with oncology to know the ability to correct and you know, tremendous deformities. Now, you can look on the surgeon map and get an idea of how much correction you can get by just getting a few degrees at multiple levels. It's really amazing. You know, a lot of people do what are called osteotomies to get terrific correction in the spine, and you find that by just doing several osteotomies at a few levels, you can correct a tremendous amount of deformity.
Mm-hmm. Okay.
Yeah, thanks for the insights.
What are you doing? What's your research?
Well, actually, I'm working on secondary decellularization. I will start to be working with Dr. Austin Clapp. I don't know if you've heard of his research. So we're basically working in the field of bioengineering. It's yeah, it's like we take done the research for in Egypt. I've used livers. It's you take a liver donor or organ from a deceased donor, you decellularize it, and then you have the scaffolding, and from then you like repopulate it with stem cells, and it holds a lot of potential in future transplant surgeries.
Wow, that's new stuff.
Yeah, very interesting.
Very interesting stuff.
Yeah.
And Richard, we'll have to get you on a hangout to talk about that.
Yeah, well, I get to talk about it later.
Well, Sajeesh, do you have any questions of Dr. Mendel? Satish, you're muted. You have to unmute yourself.
1 second. Okay, so yeah.
There you go. There you go.
Yeah, hi, Richard. Nice
Hi.
to meet you again.
Hi, how are you?
Wonderful talk. Just a quick question. What would be your optimal age for doing a scoliosis correction?
Well, that really depends on the problem at hand. And like I said, I like scoliosis. I'm not an expert. I've just listened to a lot of guys. It depends on whether you've got neurologic issues going on. Like, for instance, kids that have a problem with scoliosis and may have a meningomyelocele or that kind of problem. That's something that's going to be fixed at a very early age in order to try to preserve urinary continence and that kind of thing. But the ages have changed a lot. I remember when I was a kid, and a friend had scoliosis. She was kept in a brace forever, and it never did anything, and she ended up needing correction anyway. But really, I would tell you to look at that Scoliosis Research Society e-text. It's a tremendous text. It's free, and you can you've got the best people in the world for scoliosis have authored the thing.
Right. Yeah. Well, I suppose the issue would be when you want to fix a plate and screw, you really need to have good bone. So that's what I was trying to find out. What's a time when you have a bit of bone where you can fix a screw in the spine?
Well, the children do very well with the pedicle screws because the pedicle screw purchase is really in cancellous bone, not the cortical bone.
Oh, okay.
And so when you look at the biomechanics of it, when they have a really healthy cancellous bone, the pull-out strength is excellent, even though it's not, even though it's cancellous, it's not the cortical bone it's in.
Right.
As you get older and you have less and less cancellous bone in old age, it's much less forgiving.
All right. Okay. Yeah. Thank you, Richard.
Oh, you're welcome.
Richard, is body casting falling out of favor, or is it getting more surgical now?
Well, I don't want to. I can't speak for most PD stuff. I haven't seen. I've seen a tremendous lessening of bracing and the spigot cast. I don't think I've seen one in years.
Right.
Yeah,
it's falling out of favor.
Yeah, it's falling out of favor. Yeah.
Okay. I did see that Dr. Vaccaro, Dr. Albert, Roth, and they would sometimes put somebody into cast them into a position that they felt was advantageous before surgery so that they were positioned well on the table, because you almost always, if you're going to make an error, the error isn't an overcorrection, it's usually an undercorrection.
Okay, Simon, you have a question?
Yes, thank you. Dr. Mendel, a question regarding, you were saying how life is a kyphotic process, and I wanted to just comment. When I came to Japan 24 years ago, one of the interesting things I noticed was there were a lot of old ladies working on the side of the streets. They used to have these stalls, and they used to carry their little backpacks back with them, and all of them were really bent over with severe kyphosis, and I was wondering whether that was the result of them carrying those big backpacks, one. And second, I've noticed in the last 5 years or so that they have disappeared. I imagine a lot of them have passed away, but I don't see that severe kyphosis anymore. And is it possible to correct an old lady's severe kyphosis, the lumbar spine?
Well, yeah, it really is. But the thing about the question you asked, I don't know if there's a cause and effect relationship. But you have to remember with Asian people of far Asian people, they're very fair-skinned. When you look at Chinese and often Japanese, well, especially the Chinese, are so pale-skinned that there's a significant relationship between pigmentation and strength of bone. You know, the fairer-skinned you are, the more predisposed you are to osteoporosis. And you know, I almost never see people from real African descent. I don't see them very often getting things like kyphoplasties or compression fractures like I do in paler skinned people.
Wow, that's interesting. That's very interesting. I never heard that.
Yes, it is.
Yeah, and you don't have to be. You don't have to have a lot of pigmentation, but the bone seems to be much more vigorous, stronger in people with more pigmentation. I think I mean, I can't tell you I read a journal article on it, but I would be certain there's some correlation there.
I've also, I'm just wanted to share something on it. Maybe, what is the age group that you noticed, Simon? Is it elderly population that,
yeah, they're
elderly
all
women
ladies
you're
that
talking
seem
about?
to be in their late 70s and 80s.
Yeah.
Of course, not younger people, but recently I don't see any of them.
Because,
not,
most probably it could be osteoporosis, predisposed of the weight bearing there.
I mean, they're bent over like this. They're like that.
Yeah, this too, maybe. Yeah, because that's how the bones collapse.
Many of them. I mean, a lot of them. Yeah.
Yeah, that's how the pressure affects.
There are less side streets also.
Now,
and these days there's more care about bone care, osteoporotic prevention. So that's why maybe you're not able to see those.
Could be.
Oh, okay.
Remember the other thing. I was listening to somebody from The Economist, and they're saying now that China is really becoming one of the most aged. Both Japan and China are becoming some of the most aged populations in the world. Because for a long time, with China's government, people were only having one kid. Now they're having multiple children again, but that's a very much older age group now, China.
Okay.
So I'm sure that's part of it.
Okay.
Thank you.
Okay. Any more questions from the panel? Mohammed, any more questions?
No, that was the.
Okay.
So, Dr. Mendel, I've got a last question. This is about the chiropractors, management in these kind of situations. Do they really help, or is it like a? I always wonder about how this chiropractor works.
Oh, to correct the deformities?
Yeah.
Okay. I didn't realize it was used.
Well, you know what? The only thing I'm going to say about that is that, well, I'll say two things. One is that the neck is incredibly high-priced real estate, and I don't think anybody but yourself should crack your own neck, because if you have somebody adjusting your neck and it starts to hurt, it's too late to scream and tell them to stop. You can adjust the thoracic and lumbar spine all you want. There's so much muscle around it. But the other thing I will say is that when you're a doctor and you're an orthopod or neurosurgeon, the last thing you really want to see in your office is somebody with back pain that's been severe for 2 or 3 days or a week, because those people need to fail 6, 8, 12 weeks of therapy before you would ever think of really operating on them, right? So it really burdens the system to see people that don't need to see a surgeon. They're at least 3 months away. but there's not enough nurse practitioners, or you call up an orthopedic office, tell them you've had 2 days of severe back pain and when can you get in, and maybe they'll put you in with a provider, an affiliate provider or something, but they don't really want to talk to you until you've at least failed some therapy. So I think a lot of people like their chiropractor because they can go see them, they can call and go see them 2 hours later, and it gives them somebody to talk to. But I mean, you'd have to be in awful shape to acquiesce to surgery after a 10-day period of rehab or whatever. You don't want to operate on people with ridiculous pain for a really short time, and there's very little proof that surgery for back pain, not deformity, not neural compression, but back pain alone, mechanical back pain, is successful. And I think Dr. Resnick has been publishing a lot on that at the University of Wisconsin recently, and you can look at Bogduck's book. He's from Australia, Nikolai Bogduck, at the biomechanics of the back. But it's hard. The chiropractors serve. They can handhold. They make the patients feel better. The patients love them, so that's fine.
Well, low back pain, as you know, Richard, is such a difficult problem for all doctors. But I knew an orthopedist I trained with, and he did not like to see. He's an orthopedist. He did not like to see low back pain patients, and he would charge those patients double, just to make them feel relaxed about seeing them.
Well, I think we learned a lot from orthopods. I mean, orthopods, they tend to subspecialize and work well in groups, and so now the groups are not small groups. They're usually big groups of many people. You have shoulder people, knee people, spine people, and so you can't afford to be an orthopod who won't see 5 different things, because then you're out of business. You need to be in with a group so you can funnel those patients to somebody. But you know what? Funneling that patient to your spine colleague isn't really that effective either. What you want to do is see the patient, get them into some kind of physical rehab or exercise regimen, rehab thing, and then have the spine guy see them 6 to 12 weeks. But people don't really like that anymore. They want instant attention and gratification.
Right.
Like they'll sit there and tell me how much they don't want surgery, and I sit there thinking to myself, well, why are they coming to me? Why are they coming to me, a stupid surgeon? I'm going to only recommend one thing: surgery or not surgery.
Yeah. Okay. Any more questions? Anybody? Very good. Okay, Richard. Thank you very much again for an excellent presentation.
Thank you. Very nice.
Thank you for all the members of the panel. And hang around after, we can chat, but I'm going to sign off. So thank you very much.
Thank you.